So good afternoon, everybody. Today we'll start with the chemotherapy of chemotherapy of bacterial infections. So the first class is cell wall inhibitors. So can you tell me the examples of cell wall inhibitors? Penicillins, yeah. Cephalosporins. What else? Polymyxins. Polymyxins example colistin. Then monoractams example. Meropenem, yeah. So and estrionan, that one class. So these are the basically cell wall inhibitors. So today I'll focus on cephalosporins, the first class. So we have 5 generations of cephalosporins. I'll start with the mechanism of action. That is, they act as cell wall inhibitors. So how is bacterial cell wall made up of? Like, do you know the structure of bacterial cell wall? Like, how is it made up of? Yeah, so we have peptidoglycan bilayer and lipopolysaccharide layer. So the difference between gram positive and gram negative is, in gram positive we have high content of peptidoglycan layer and low content, like for example 3 layers of peptidoglycan and just 1 layer of lipopolysaccharide. Okay, but when it comes to gram negative, we have the reverse: more layer of lipopolysaccharide and less layer of peptidoglycan layers. So the main action of all the cell wall inhibitors are, they will inhibit this peptidoglycan layer. How? So we have a structure in the cell wall. That is, this is the structure. Okay, that is, it is beta 1,4 linked NAM, that is N-acetyl muramic acid, and it is linked to N-acetyl glucosamine. Okay, and in between we have this peptide chains. Okay, so this is a cell wall made up, cell wall. Okay, that is a peptidoglycan layer. So this layer is subjected to a remodeling process. How? In the presence of this enzyme called as transpeptidase enzyme, this peptide bonds tend to break down. Okay, like they'll break down and they'll remodel. So this happens in the presence of this enzyme called as transpeptidase enzyme. There are other enzymes also called as, it is a type of enzyme, it is a type of enzyme which comes under the class penicillin binding proteins. Okay, so transpeptidase is one such enzyme. So how does the cephalosporin act? Is it will go and inhibit this transpeptidase enzyme. Okay, so when this enzyme has been inhibited, this cross-linking doesn't take place. So when this cross-linking doesn't take place, the remodeling process doesn't take place. Only if this gets remodeled, what is this? Your cell wall. So if this is not getting remodeled, your cell wall is not being formed. So now the bacteria is left with only cell membrane. So they are prone to a high amount of autolytic enzymes. So once there is this cell wall remodeling, there is no cell wall, the autolytic enzymes in the bacteria has been activated. So this is known to cause cell lysis. This is known to cause cell swelling, cell lysis, and finally death of the bacteria. So that is in case of gram positive. So peptidoglycan layer is more in gram positive. So that is useful. So how can you tell me? How is it in gram negative? Because more of peptidoglycan is less, right? So how does it take place? Because we have outer membrane as lipopolysaccharide when it comes to gram negative. So how? So in this gram negative bacteria, there are some channels called as porin channels. Okay, porin channels. So this cephalosporin attaches to this porin channels and then enters the lipopolysaccharide layer and comes to the peptidoglycan layer, and then the whole process will go and inhibit this enzyme, and this remodeling doesn't happen and all this, so ultimately resulting in cell death. So that is why penicillin comes under the cephalosporin comes under the class called as cell wall inhibitors. Okay, so now coming to the drugs. So we have 5 generations of cephalosporin. So how many generations did all of us learn? Starting, I think initially we just learned 4 generations, right? So 5th generation, actually this has been this was been approved around, the first drug was approved around 2010 and the second drug was approved around 2013, but then we don't use it practically. Okay, so we're coming to the generations. So initially I'll tell you the history of cephalosporins. How is cephalosporin being used? So we had a person called as Botsu, Bortzu, Botsu, okay, in 1948. So he found a fungus mold along the seaside. Okay, so he took that fungus mold and he tried to treat a kind of infections. Okay, later it was known as that is streptococcal infections. Okay, streptococcal and another infection called as typhoid. Yeah, so this particular mold was able to cure that infection. Okay, so later on they understood that this mold was named as Cephalosporonium acrimonium. So that is the derivative of cephalosporin. Okay, Cephalosporonium acrimonium. Okay, This was the fungus mold. So from this fungus mold, they derived 3 antibiotics. That is cephalosporin C, cephalosporin P, and cephalosporin N. Okay. Among these 3, they found that cephalosporin C is known to have high antibacterial effect. So that is what they isolated from this mold, the cephalosporin C. So that factor is called as, today we semi-synthetically derive that as 7-aminocephalosporinic acid. Okay, 7-aminocephalosporinic acid. Okay. So can you tell me the structure of cephalosporin? How is it? Beta-lactam ring. So we have a beta-lactam ring. So in that, I don't have place, so I'm just telling it. So in that beta-lactam ring, we have a position called a 7th position. Okay. In the 7th position, this thing is added, cephalosporin C. That is the 7-aminocephalosporinic acid. So that is the difference between penicillin. Penicillin doesn't have this particular factor, 7-aminocephalosporinic acid, and that is in the 7th position. Then in the beta-lactam only, there is a 3rd position, that is somewhere towards this side. This side, there is a 3rd position in the beta-lactam ring, that is like R3 or something. So this position is known to cause changes in the pharmacokinetic properties of all this. So changes in this resulted in all these generations. Okay, because of the changes in the cephalosporinium 7, that is the 7th position, we got cephalosporin something which is different from penicillin. And because of the changes in this R3 position, we got all these generations. Okay. So now let's look into the drugs. So coming to the generations, initially all these generations were discovered based on the time of discovery. That is why it was called as first generation, second generation, third generation. But then later on, like as time passed, this generation came to a focus of based on the antibacterial spectrum what it inhibits. Okay, so initially the first class were highly active against gram-positive bacteria. Okay, the trend goes like this. From first to, if you go lower, it comes from gram-positive to gram-negative. It will end up in gram-negative. Okay. Okay. So initially it was classified based upon the time of discovery. Later on it got classified based upon the type of the organism what it inhibits. So first generation, second generation, third generation are called as such because of the time of discovery. From 4th generation they were named as different. 4th generation cephalosporins are called as anti-zoodomonal cephalosporins. Okay, Zoodomonas aeruginosa. So that is highly it is a dangerous it is a kind of weird microorganism. So it is kind of a strong microorganism. So from 4th generation it is called as anti-zoodomonal. Okay, and the 5th generation is called as anti-MRSA cephalosporins. Okay, not, you won't tell them as 5th generation, anti-MRSA cephalosporins. Even 4th is called as anti-zoodomonal cephalosporins, not 4th generation. Okay, so this is anti-MRSA. So can 5th years tell me what is MRSA? 5th years. MRSA. Okay. Methicillin resistant Staphylococcus aureus. Okay. MSSA is methicillin susceptible Staphylococcus aureus, and we have different types. Again, in resistant species we have different types: methicillin resistant Staphylococcus aureus, methicillin resistant Enterobacteriaceae. All these are gram positive. So you can tell that 5th generation is more focusing on gram positive resistance versions. All that Staphylococcus aureus, Staphylococcus Enterobacteriaceae, all that. So it is focusing on gram positive resistant species. Okay, so that is the difference. So now we'll directly go into the drugs. So coming to the drugs, first generation oral cephalosporins and parenterals. So in this first generation, the only drug what we are using is cephalexin. Okay, and parenteral is cefazolin. Okay, so just remember, obviously it's difficult to by heart the whole cephalosporins, right? So first generation oral cephalexin, parenteral cefazolin. Okay, and first generation is more active against gram positive. So whenever you have gram positive infection, so before that you will have to know what are the gram positive. So the 5th years doesn't know. So we had a class on classification of microorganisms. So the seniors will tell us what are gram positive organisms.
We have a video of it. Staphylococcus aureus, Streptococcus pneumoniae, all the species.
Okay. Staphylococcus aureus, Staphylococcus epididymis, and Streptococcus. So these are the gram-positive cocci. So basically, first generation is more focused on gram-positive cocci. Okay, and okay, so in this oral is cephalexin and parenteral is cefazolin. So cephalexin, the normal dosing is 250 to 500 mg every 6 hours. 250 to 500 mg every 6 hours, and cefazolin is 1 to 2 grams IV or IM every 8 hours. So that is a normal dosing of cefazolin. So now coming to these drugs. Cefadroxil was the first drug which was found in oral cephalosporins. Okay, this is a prototype drug, and from this a modified version of the drug was formed, that is cephalexin. So cephalexin's prototype means the first drug which was formed. So cephalexin's prototype was cefadroxil. Okay, and in this parenterals, cefazolin is found to have the longest duration of action. So that is why that is the only parenteral drug what we are using in the first generation. Okay. And gram-positive organisms are streptococcus and staphylococcus. So from that you can understand where does staphylococcus live. It lives on our skin. So it is useful in skin infections, surgical infections, like again you are cutting your skin, right? So surgical infections and streptococci, upper respiratory tract infections, and also that is the indication of first generation. Okay, skin and upper respiratory tract infections. Okay. Now coming to second generation, oral cefaclor, cefaproxil and cefuroxime acetyl, and parenteral is cefuroxime sodium, cefoxitin and cefotetan. So the simplest one, cefuroxime acetyl. So that is available both as IV and parenteral. So acetyl is the oral form and sodium is the IV form. So this is the only drug which has been used in this class. Okay, so you know what is second generation. So first generation is cephalexin and cefazolin. Second generation is cefuroxime acetyl and cefuroxime sodium. Okay, so the dose of cefuroxime is 750 mg to 1.5 grams IV every 12 hours. IV, it is 750 to 1.5 grams IV every 12 hours. And the oral form is 250 to 500 mg per oral every 8 hours, 8 to 12 hours. Okay. 250 to 500 mg every 8 to 12 hours. Okay. Okay. So coming to parenterals, again in this, the first generation cefazolin was the first parenteral. In second generation, cefuroxime sodium was the first parenteral agent which was being formed. Okay, and this is the first drug which tried to cross the blood-brain barrier. Okay, so the first generation doesn't cross blood-brain barrier. So this is having poor CSF penetration. So this is not having best, it's having better CSF penetration. So again, it is not still useful in all your meningitis and all. It has not yet been useful. Okay. Next, coming to the third generation, I told you the trend decreases. So it is more active against gram-positive. This is having modest activity against gram-positive, better activity against gram-negative. Now coming to the third generation. Third generation is completely gram-negative. Okay, less active towards gram-positive. And again coming to this, ceftriaxone is the only drug in the third generation which is known to be active against both gram-positive and gram-negative. That is ceftriaxone. That is why any infections, any drug chart you see ceftriaxone 1 gram BD. So that is because it covers the whole, most of the antibacterial spectrum. Okay, and cefotaxime, cefoperazone we use it as combination with sulbactam. That is called as Magnix Fort. Cefoperazone plus sulbactam. Okay. And ceftazidime, this has been recently used for all the high infections, that is as a combination, that is with ceftazidime plus avibactam. Okay. Okay, so since from third generation it was active against gram-negative. So gram-negative spectrum is found to be a little more bigger, right? So that is why resistance actually started from the third generation. Okay, so that is why we give most of the third generation drugs in combination, cefoperazone plus sulbactam, ceftazidime plus avibactam. Okay, again if you look into some journals, the ceftazidime, right, recently we started using it in combination with avibactam. So ceftazidime, if you look into some journals, it is classified under fourth generation. Okay, I'll tell you the difference. These are covering gram-negative, but it doesn't cover Pseudomonas. Okay, ceftazidime is only third generation cephalosporin which covers Pseudomonas. Okay, but it was discovered during third generation time. That is why it is included under third generation, but based on spectrum, if you're classifying, it's included under fourth generation. Okay, that is ceftazidime plus avibactam. Again, combination is better than the single dose. Okay. So in this, the oral form what we commonly use is cefepime, and the parenteral is again ceftriaxone, cefoperazone, ceftazidime, most of the third generation. So the ones which we are using highly is third generation cephalosporins. So I'll tell you the doses. Okay, ceftriaxone, the dose is 1 to 2 gram IV every 12 hours. Cefotaxime 1 to 2 grams every 8 hours. The best thing about third generation is everything is 1 to 2 grams. Only the timing differs. Ceftriaxone every 12 hours. Cefotaxime every 8 hours. Cefoperazone again 12 hours. And ceftazidime every 8 hours. Okay. So, ceftriaxone and cefoperazone every 12 hours. Cefotaxime and ceftazidime every 8 hours. Okay. So that is about third generation, okay? More towards gram-negative. Only ceftazidime is having activity against Pseudomonas and ceftriaxone is having activity against both, okay? And coming to the fourth generation. So the thing about fourth generation is up to here you could find oral formulations. So fourth and fifth is only parenteral formations, okay? Formulations. So in this, the commonly used drug and the one which is available, okay, the commonly used drug is cefepime, okay? And one thing, positive part about cefepime is it's having the same property as ceftriaxone. Why? Because ceftriaxone is active against gram-positive and gram-negative. So cefepime is such kind of a drug, which is active against gram-positive, gram-negative plus Pseudomonas, okay? So the dosing of cefepime is 2 grams IV every 12 hours. 2 grams IV every 12 hours. And cefpirone is 1 to 2 grams IV every 12 hours. Cefpirone. And one positive part with cefpirone, I mean, one extra add-on part is you will have to give a loading dose. That is so cefpirone is the only drug that is a cephalosporin in cephalosporin class. This is the only drug which is given as loading dose, cefpirone, okay? That is, it will require a loading dose of 2 gram IV, then maintenance dose of 1 to 2 gram IV every 12 hours. Next is ceftolozane. Again, this is recently been given in combination with tazobactam, but we have not used it officially. This is under studies. Ceftolozane plus tazobactam is under studies. Actually, it's been there from a long time, but then we have not been using. So the combination of ceftolozane plus tazobactam. And finally, coming to the fifth generation, that is a anti-MRSAs. So that is again available as parenteral, that is ceftaroline and ceftopirole. So the dose of ceftaroline, because this has not yet been used, but then commonly what you find is ceftaroline, like most of the studies. So the dose is 600 mg IV every 12 hours. So this is only, again, most of the cephalosporin is 1 to 2 grams. So this is the only IV formulation which is having 600 mg every 12 hours, okay? So if you look at now I think most of us are okay with classification. Like we can remember at least some drugs. It's not important to remember all the drugs because we don't use everything. What we commonly use here what we commonly use all the surgical procedures, first generation. Then LRTIs and all, they'll use a third generation. And fourth generation, very rarely cefepime they'll use. Again, I think somewhere in surgical department, it's very less. So ceftriaxone, just be thorough with the third generation. That is what we're commonly using, okay? So ceftriaxone, just one add-on point. Ceftriaxone is given 1 to 2 gram IV. So most of the prescription, if you look at, we are giving 1 gram BD, right? IV BD. So ceftriaxone is used as 2 gram only in one condition. Which is that condition? Correct. Okay, and one add-on part is all these third generation, they'll cross the meninges only if the meninges are inflamed. So that condition is called as meningitis. So in normal individual, if you are giving ceftriaxone, obviously it doesn't cross the meninges. So no CNS symptoms, okay? So that's it about the drugs. Next, I'll come to the adverse drug reactions. Adverse drug reactions, the common adverse drug reaction with all the beta-lactam antibiotics is hypersensitivity reactions, okay? So, cross-reactivity, we have something called as cross-reactivity, right? So, hypersensitivity reactions with cephalosporins. Cephalosporins are IgE-mediated hypersensitivity reactive drugs, okay? IgE mediated. So when it comes to penicillins, we have two types of hypersensitivity reactions, that is IgE mediated and non-IgE mediated. IgE mediated is called as acute hypersensitivity reactions, and the other one is subacute hypersensitivity reactions. So the subacute part is formed by IgG mediated, okay? So IgE mediated in penicillin, I'm talking about penicillins. In that, the natural penicillins, that is penicillin G and penicillin B, they are known to cause IgE mediated, the natural ones. Whereas the non-natural, that is the semi-synthetic, all this ampicillin, amoxicillin, piptas and all. So these are known to cause non-IgE mediated, okay? So whenever you find a patient on penicillin medium, so you have to, penicillin allergic patients, you'll find that red chart, right? You have to ask them which type of penicillin. They'll tell penicillin. So if it is natural, okay, that I'll tell you 1 minute. So when it comes to cephalosporin, all the hypersensitive reactions are IgE mediated only, nothing else, okay? And again, the trend decreases. The highest IgE mediated is in first generation. So as it decreases, IgE mediated is reduced. So hypersensitive reactions, by the time you come to third generation, is less. Okay, so that is why I think you might have seen, even if the patients are allergic to penicillin, they will be given ceftriaxone because IgE mediated is very less. The IgE mediated hypersensitive reactions is very less. Okay, so whenever you find a patient on penicillin drug allergy, you'll have to ask which type of penicillin. If it is natural penicillin, so obviously it's better not to give first generation, second generation cephalosporins. If it is non-IgE mediated, like if, for example, if they are allergic to amoxicillin, giving cephalosporins is not much concern because this is IgE mediated, whereas that is IgG mediated. Only the natural one is IgE mediated, okay? So that is the first adverse drug reaction of cephalosporins, that is hypersensitivity reactions. Next comes nephrotoxicity. So yeah, that is one main point. So all of the cephalosporins except ceftriaxone requires renal adjustment. Okay, all the cephalosporins except ceftriaxone requires renal adjustment, and ceftazidime except ceftriaxone and ceftazidime, all the drugs requires renal adjustment. Okay, and none of the drugs requires hepatic adjustment except ceftazidime. So ceftazidime doesn't require renal adjustment, but it requires hepatic adjustment. The maximum dose is 2 grams per day. Okay, so that is the only thing. So most of the drugs are known to cause necrosis of your. It's known to cause nephritis. So tubular nephritis, and then it can lead to neurotoxicity. So dosage adjustment is required. So mostly it is below 50 ml per minute. Mostly below 50 ml per minute, you'll have to check for the adjustment in case of cephalosporin. Most of the drugs is below 30 ml, right? But then when it comes to cephalosporin, below 50 ml dosage adjustment has been recommended. Just check out the guidelines. It is there. Ceftriaxone. So that is why, again, a plus point why we use ceftriaxone in all the patients, because no renal adjustment, no hepatic adjustment. And cefuroxime is actually requiring hepatic impairment. Okay, it is not ceftazidime, it is cefoperazone. Cefoperazone is the cephalosporin which doesn't require renal adjustment but requires hepatic adjustment. Okay, so again, when you are giving it in combination, cefoperazone plus sulbactam. Sulbactam requires renal dosage adjustment. Though cefoperazone doesn't require, sulbactam require renal dosage adjustment. Okay, so that you'll have to see again. So that's it about ADA. So first was hypersensitivity reactions, nephrotoxicity, then it was known to cause diarrhea. Most of us know why it causes diarrhea, because the antibiotics is known to alter our microbial flora, and this can result in diarrhea. Okay, and there's one more thing with ceftriaxone. So ceftriaxone is known to cause precipitation with calcium compounds. So that is why whenever you give ceftriaxone with renal lactate solution, it is always contraindicated. They'll tell it is known to cause precipitation. Okay, ringal lactose. Okay, so that is one thing we'll have to look for, and yeah, and there is sometimes very less chances. There is chances of hypoprothrombinemia. Okay, so that is decrease in prothrombin type. Okay, hypoprothrombinemia in very rare conditions. So that is again not much common. But the one which is very common is nephrotoxicity. So it's better to go for dosage adjustment. So that's it about cephalosporins in general.
Good there. So another thing is